Hi everyone, we're planning to kick off at just around 9:30. I think we've got a few more people hopefully joining us. We sent out an email this morning because we will be recording the session, because a few people, or quite a few people, can't join us because they've got other commitments this morning. So they've asked for the presentations, which is great because we want to get our message out there to everybody. And there's hopefully going to be a really interesting session this morning, which you should all enjoy. So we'll kick off formally shortly, but thank you everyone who has already joined us for spending some time with us today. Okay, everyone, shall we get going? Because it's 9:30 and we've got a packed morning, so I don't want to be the one person that ruins the timings for everybody else. So let me introduce myself. I'm Kath Norton. Most of you will probably have seen me talk around neurodevelopmental issues previously. So I'm a community paediatrician. I'm based in Cardiff, but I'm also the chair of the Neurodevelopmental Workstream Entered Together for Children and Young People Part 2. I work with many of you, and what this meeting is doing this morning is actually replacing what would have normally been our quarterly summer, both our national steering group meeting and our national clinical lead meeting. So thank you for so many people joining us today. Now, one of the reasons for getting this meeting together was, one, everybody wanted to see each other and to catch up, and they missed the separation of the steering and the clinical group. So this is listening to you and taking it forward. Plus, there's so much good work going on out there. There's so many ideas, so much innovation. We wanted to give the opportunity to really showcase some of that. The other key issue with our work is that it is very much a collaborative effort. And I think that's reflected in the participation in this morning's meeting. Everybody's coming from very, very different backgrounds with different experience. We've got parents here, we've got carers here, we've got young people here, we've got clinicians here, we've got managers, we've got academics. If I haven't mentioned you, apologies. But it is meant to be collaborative. It's also hopefully interactive. There's a couple of options for interaction, in the sense that there is, we're looking for some feedback. So there's been an email come out to you this morning with the link. It's also on the chat bar for your feedback to help us build future sessions. There's also going to be a couple of question sessions. So if you want to raise a question, pop it in the chat bar. Deb Austin has very kindly agreed to collate those questions, but don't worry, if it doesn't go in the chat bar, you can always put your hand up, and we'll do our best to coordinate some robust question sessions, one after the first couple of presentations, and another towards the end of the morning session. So get your thinking hats on for what you want to ask, because this is all about collaboration, participation, and representation. Now, before we go into the content of the meeting, I just wanted to assure you that we are continuing to move ahead with the business aspects of our work, because this is clearly replacing 2 different business meetings. It's not us taking an early summer break. Next week, there's the programme board for Together for Children and Young People. And next Wednesday, we've also got a 25-minute slot with the 3 ministers. So covering education, health, social care, mental health in that way. And that will be a fabulous opportunity to take forward additional comments and representation from today's meeting. And to assure you that there's quite a lot of tangible work going on already around neurodiversity and neurodevelopment, both in terms of this sort of meeting where we are taking forward the discussion around difference, not disorder, and what this means in terms of future service delivery. But we're also moving forward on quite a lot of work around practical enablers. You're going to get an update later on the digital tool and the digital platform, which is seen as an opportunity to really enhance the implementation of the standards and to enhance the collaborative assessment of children and young people who may be neurodiverse. We're also working very closely in collaboration with our colleagues in education who are working on ALM. And we're also looking at professional learning modules and training modules. We're looking at enhanced ways of looking at demand and capacity. So we've worked with the NHS Collaborative, the commissioning benchmarking team, and with the delivery support unit around a new model for a benchmarking tool, because all of the clinical teams very kindly test trialed the existing one, and frankly it does need some further work. So lots of innovative work going forward there. And I'd also like to emphasize a huge opportunity for ongoing and active collaboration with the Integrated Autism Service, who have been fabulous in terms of welcoming us alongside them to really look at the range of services and opportunities and innovations that we could consider. So if we move forward really to our next slide. So what I'm going to do here is, just before we kick off with the really interesting speakers, is orientate us a little bit around the Welsh approach and the Welsh model. Many of you will have seen numerous presentations around this, and you'll be pleased to hear that we've actually distilled this down to an incredibly short series of slides now. But it does contain a lot of information, and those that are new to us, I apologise for the speed that I'm going to whistle through this. So our approach in Wales is about difference, not disorder. It's about a positive, strength-based approach. But we're also looking at what that means in reality, what this means for services, for service design, for funding of services, for delivery of services across Wales. And a key element of our work within the programme is around the implementation of the national standards around assessment that were agreed a number of years ago, and challenging some of the practical issues that impair the actual delivery of those proposed standards. Now, we are informed by evidence and experience, both evidence coming from academic research, but also lived experience by both parents, young people, and clinicians, and they tell us the following points. Neurodiversity is common. It may affect 10 to 20% of the population. This is because we're going beyond a strict definition of autism, which might be 1%. We're looking at wider conditions such as ADHD, language differences, motor coordination differences, tic differences. So it's a lot of people, and that perhaps suggests why there is so much demand. The second thing we've learned is that despite our historical enjoyment of categorical diagnosis, what we term comorbidity, which is a rather negative word, but we're talking about the fact that people may well meet criteria for different diagnoses. So it tends to be the rule rather than the exception that an individual who is neurodiverse may well meet criteria for different medical diagnoses. However, the other spin of this is what we call co-occurrence of symptoms, which means that the symptoms of a neurodevelopmental condition aren't necessarily unique to that one condition. And you've really got to get a better understanding of that individual in context to really understand how they are presenting and why, and what those symptoms tell us. And that is why we're proposing this concept of a holistic assessment, which isn't new, using the concept of a formulation and working as part of a broader multidisciplinary team within our understanding of the guidance and the standards. And that has really great significance for how we structure our teams and our services, because no one person is going to be expert in everything. We're also clear that they are trait disorders. So those who have seen me talk before will be familiar with the bell curve. That's fine, but it becomes a problem when you base access to resource or support on a diagnosis, because you are going to have the diagnostic cutoff at one end of that curve, which leaves an awful lot of people disappointed, frustrated, struggling, and asking for help. So using diagnosis where diagnosis is relevant, for example, if you have a medical diagnosis with a drug therapy, you do want a categorical diagnosis, but you don't necessarily use a diagnosis to control access to support and resource. We're also going to talk a little bit later on around genetics of mental health, but we all recognise now that neurodiversity is a polygenetic condition with different factors. We know that different peers, different siblings present differently. We also now reflect on the fact that this may mean that we're working with neurodiverse families, and we need to consider what this means in terms of how we communicate as professionals, how we function, how we collaborate. And the next point there is one that we've emphasised a number of times, and I'm delighted to welcome Helen Minnis shortly to speak around aspects of this, really, is that there is a risk of polarising when we are overwhelmed by demand to say, well, this child has had trauma, therefore they're in this camp. This child is from a neurodiverse family, they're in this camp. This is about children and young people, and we need to stop trying to almost post-box them at a very early stage and look at them holistically in the context of their environment. So next slide, please. Why is this important? It impacts. It impacts on outcomes. It creates distress. It creates challenges. It's important. Next slide, please. So what are we going to do? We're trying to shift the balance. Keep the best of the different models. Find that sweet point. Next slide, please. Where is this sweet point? Well, that's for you to decide, really. So what we're going to look at today in today's agenda is both the specialist element and the holistic element. So I'm going to introduce to you a new slide, which is very busy. I make no apology for that at this point. The next slide, Annapurna. All right. Now, all this is meant to illustrate is that the child or the young person is at the centre of this. This is about an integrated, collaborative, holistic understanding of a child's presentation. Now, the graphics around that in green are part of the new model that has emerged from our partner limb within Together for Children and Young People, the NEST or the NITH model. And this is from the part of the work stream termed Early Help and Early Support. And it's about a high-level planning tool for how we may deliver services to improve the emotional well-being and mental health of our population. Now, the blue rim around the NEST model is trying to illustrate how we put the child at the centre, we consider the child in the context of their environment, their supporting trusted adults, and then from a neurodevelopmental perspective, we consider our enablers and our standards, how we assess, how we intervene in a quality, informed, appropriate manner, how we facilitate this process using technology, how we work in partnership. And there's a little element there termed the centre of excellence, which is this concept of a different way of working outside traditional agencies around a collaborative model to inform our work around neurodiversity. And then on the outside of this ring is this potential to develop this specialist network of clinical support, because in the NEST we are holding and supporting the child, the young person and their trusted adults. We also need to support the professional decision making, because we've just told you how diverse this situation is, how challenging it is, how we need to interpret things. So next slide, please. So we've now got 3 minutes left of my slot. We're going to move beyond our talk into a little animation that takes just 3 minutes about the NEST model, so that before we move on to our presentations around the specialist side of things, you can get an idea of what NEST actually means. Annapurna, are you okay to play the animation?
A little bird has been spreading the word all about the NEST framework, a planning tool designed to help services make sure that mental health and well-being is at the heart of everything they do. It's for everyone: babies, children, young people, parents, carers, and their wider family and professionals, to make sure they feel supported and get extra help if needed. Time was taken to talk to lots of people and listen to their ideas. It was agreed that nests were a good way of explaining what helps children of all ages to grow strong, aim high, and be the best they can be. This happens when their everyday relationships feel nurturing, empowering, safe, and trusted. Everyone's nest is unique, made up of the people who are closest to them, the things they enjoy and help them grow, their communities, and the places they go to in their day-to-day lives. Trusted adults play a vital part in a young person's nest. They can lift them when they are sad, encourage them to try new things, help them join in with others, and make them feel valued and cared for. This is the everyday magic that builds and maintains positive mental health and well-being. The NEST framework aims to organize services so that more people get to experience this everyday magic in their daily lives. It also aims to help children and young people feel a sense of belonging, which is so important to mental health and well-being, whether that is at home, in school, at a club, with friends, or in their community. And when things aren't going well, like when a child or a young person is feeling sad, anxious, left out, or so angry that they push people away, the trusted adults who know them best will have access to support, giving them lots of ideas to try and the confidence to keep helping. That's because sometimes what a young person needs most is for trusted adults not to give up. NEST recognizes how important trusted adults are. When they are well supported, it can make all the difference. Sometimes, of course, extra help is needed, and the NEST framework's no wrong door approach recognizes that everyone is different and there should be lots of different types of help available. That way, all services come together to work out who can best meet the unique needs of each person. This makes sure children and families aren't bounced around services and gives access to the right help at the right time in the right way for them. We all need different kinds of help at different times along the way. The NEST framework aims to support children of all ages, parents, carers, their wider families, and the professionals who help them. It's about making sure everyone has opportunities that are nurturing, empowering, safe, and trusted. Learn more about NEST today.
Thank you. So I'm now delighted to be able to move on to the content of our programme this morning. We've got 2 presentations first, and then we'll have an opportunity for questions. I'd remind and encourage everybody who's got questions, pop them in the chat bar. Deb's going to collate them. If you can't think of a question at the time, don't worry, we can come and take queries afterwards. So I'm delighted now to welcome Professor Helen Minnis from Glasgow to discuss with us what's behind the trauma. Over to you, Helen.
Hi, would it be possible for me to share my own slides? I think I prefer that if possible. There's lots of animations if I can share.
Yes, it's absolutely fine by me. I'm sure that's not a problem.
There we go.
There you go.
Oh, except I'm sharing the wrong screen now. Just give me a second. I know I use all of these, I use animations, and it just makes it easier if I can share my own. Except it's being a little bit fussy for some reason. Why is this being such a pain?
Because it can, Helen, don't worry.
Yeah, I mean, I've got the screen open and I don't know why it doesn't want to share this particular screen.
Happens to me on a daily basis.
Except that's not the right presentation. I don't understand this. Okay, can you... Oh, it's so annoying. Sorry about that, everyone.
It's okay, Helen. Everybody has been there before you, so do not worry about that at all.
Yeah, I mean, I've never had this happen before. I must say it's very strange. I've literally got the presentation open on my desk, but it's not offering me this one. But just give me a second, I'll be with. There we go. Can you see that? Okay.
No, it's on my screen. It's saying the content can't be displayed. Don't know if it's showing on anybody else.
I can see it.
I can see it.
Yes, I can see it. I can see it as well.
Yeah.
Okay,
Yeah.
if everybody else can see it, that's absolutely fine.
Something
I feel slightly
strange.
selected out, but no worries.
Very strange. Anyway, good morning, everyone. I'm Helen Minnis. I'm a professor of child and adolescent psychiatry, and you will know this already, because I know that ACEs have been, discussed a lot in Wales. We know that adverse childhood experiences are associated in a dose-response relationship with poor outcomes in adulthood, and this is a dose-response relationship for depression. But what really surprised scientists and clinicians was that there was also a relationship with physical health problems like heart disease. So what this shows is that if a person has 7 or 8 adverse childhood experiences, and these can be abuse or neglect, but they can also be things that are much more common, like having a parent who has a mental health problem, then you're at 3 times the risk of heart disease. So the bigger the load that the child is experiencing, the bigger the risk of later poor outcomes. And there are certain problems that are known to be specific to people who've experienced abuse and neglect, so the most severe adversities. For example, disinhibited social engagement disorder. So Kath was talking about, diagnosis versus traits. And the thing about disinhibited social engagement disorder is that it's characterised by indiscriminate sociability, indiscriminate behaviours, boundarylessness. So whether or not you think about it diagnostically, that's the key. And this is our previous research assistant, Rachel Pritchett, in an orphanage in South Africa, experiencing what I experienced when I worked in an orphanage in Guatemala many years ago. Children just being covered with children, basically. No stranger anxiety. You would only diagnose DSED in the context of abuse and neglect. And then there's reactive attachment disorder, where children fail to seek or accept comfort. And obviously we all need the help of parents, as Kath's lovely animation showed. And children who have been abused and neglected sometimes don't go for help or comfort when they really need that help or comfort. And in adulthood or adolescence, this manifests itself as trust issues. And both of these, DSED and RAD, are associated with problems with regulating emotions. And again, you would only diagnose reactive attachment disorder if there's been abuse and neglect. But there's a conundrum at the heart of this, because the bigger the load, the bigger the risk. But only about half of all children who've had even extreme adversities like abuse and neglect actually go on to have health problems. And yet, if children or adolescents or adults do go on to have mental health problems in the context of abuse and neglect, they seem to be really particularly complex and overlapping. So it's such a conundrum. Many people in the population who've experienced abuse and neglect don't have any problems to speak of, and others who do have problems seem to have a big overlapping load of problems. So we wondered whether this complexity could actually be basically neurodevelopmental, and this is something obviously that you've been thinking about. In Wales, ADHD are known, and autism, for example, are known to be heritable. And this is a quote from your own Anita Thapar, just showing that there are important genetic overlaps between autism and ADHD. And actually, a Swedish group has shown that there seems to be a kind of general heritable factor responsible for the overlap a lot across all neurodevelopmental problems. And this is something that you see in families. It's not uncommon to have a child with ADHD and an auntie with a tic disorder or autism. So we decided to look at this in a big population study just to see if my clinical impression of this high degree of complexity was correct. This is Lisa Dinkler, who led the statistical analysis. And we asked the question, do children exposed to maltreatment actually have an increased load of neurodevelopmental disorders, so increased neurodevelopmental complexity, compared to children who haven't been exposed to abuse and neglect? Very big study, and essentially asking whether there's an increased load, not of ACEs this time, but of neurodevelopmental conditions. And the answer was a very resounding yes. We looked at symptoms of ADHD, autism, tic disorders, and intellectual disabilities. And there was a group within the population that had symptoms in 3 out of 4 of these areas. And they were nearly 10 times as likely to have experienced abuse and neglect. I'm not going to go into the methodology for this, but because you can go and look at that for yourself. But what we found was we wanted to know whether this was caused by the abuse and neglect, which much of the ACEs research would seem to suggest. But actually, we found out that that wasn't the case. If you want to know about the methodology, there's a hopefully you're going to get the slides. There's a YouTube, it's only about 10 minutes, where I ask Lisa Dinkler stupid questions about the methodology. But essentially, there were additional heritable factors, genetic factors, causing both the maltreatment and this neurodevelopmental complexity. We don't know what these are for certain, but we suspect that these might be neurodevelopmental conditions running in the family. What this means is that there's an increased risk for maltreatment in children who've got overlapping neurodevelopmental problems, and that treatment strategies that purely focus on trauma are unlikely to have an effect on the amount of neurodevelopmental problems. But recognising the problems might actually help you in treatment. So we need to be, just as Kath said, we need to be taking a holistic approach and looking at this all together and not separating our services into trauma services and neurodevelopmental services. With my colleague, Ruchika Gajwani, we've looked at this, we've developed a model that we've called double jeopardy, because we know that children with neurodevelopmental problems are more likely to have problems regulating emotions, and we know that this is also true for children who've been maltreated. So, and we also know now that these two things increase the risk for one another. So could it be that children who've got this double whammy of emotion regulation problems might be the ones that go on to have severe mental health problems later? And we've got a bit of evidence for this. So we looked again in the big Swedish twin study, children who had neurodevelopmental conditions at the age of 9 and children who had experienced traumatic adverse life experiences in early childhood. That's about 1 in 100 of the population. About 2% of the population at age 15 had symptoms of mania, and mania is really something that you only see in adults. And the adverse childhood experiences did have an effect, but didn't have quite as much of an effect as the neurodevelopmental problems. And there was a double whammy. So children who had both were twice as likely to go on to have these mania symptoms.
Brilliant, thank you.
What this means is that if you have a patient where there's been abuse and neglect, or you're concerned about that, think about neurodevelopment. Think about neurodevelopmental problems first, because your patient is actually more likely than other people to have one of these or several of these conditions. And if they do have both, they're at double jeopardy of other problems. And then there's the whole thing about post-traumatic stress disorder. I'm not going to go into this in a lot of details, but there's recent discussion about complex neurodevelopment and complex PTSD. But I actually wonder whether some of the kind of relationship problems that are thought to be associated with complex PTSD, particularly in people who've experienced abuse and neglect, might actually be RAD and DSED. This is so complex. I mean, everything overlaps. Some of the symptoms are similar. What do we do? How do we untie the knot? Well, I think just be systematic. And I think first about neurodevelopment as you are doing. Think about, does this person have a neurodevelopmental condition like ADHD, ASD, a tic disorder, intellectual disability? And then if there's a history of abuse and neglect, don't forget to think about PTSD because it's very treatable. And think about RAD and DSED, and we don't have evidence-based treatments for them as yet, but just helping the person that you're working with to think about, maybe they've got some trust issues or maybe they've got some problems with boundaries, helps them understand themselves. It's all about formulation, just as Kath says. And I like to think about make and model. You know, you might want to think categorically. Am I a person, am I a Toyota or a Honda, to use a car metaphor? Am I a person with ADHD or autism? But even if you think about yourself categorically, you need to think what's inside the box. Do I have electric windshields or wind-up windshields? Do I have a sunroof or not? There's no point knowing about the diagnosis unless you know what type of person you are. So the way you're working in Wales fits perfectly, in my view, with the research evidence, and it's so fantastic to see. And I'll look forward to your questions later.
Thank you, Helen. That was great. Can everybody, I'm sure you will have questions. We're going to move on to Mena in just a moment, but pop your questions in the chat bar. I certainly have got a few brewing for you, Helen.
I have no idea now how to unshare. It's very strange. I'm in a strange sharing mode. Maybe if someone else shares, it'll just get rid of my.
I'll try and share my slides, Helen, and see if that overrides yours,
Yeah.
or whether it just destroys everything. It'll be one or the other. So you keep on chatting. I'll try and share.
You go for it, Mena. We love the challenges of IT. I think I've had a week of challenges. We've migrated 365 onto my account, so everything's gone chaotic in my particular laptop. Shortly, we're going to be welcoming Mena. So Mena is our national lead for eating disorders, and she's joining us to discuss emerging approaches for Arfid. So I'm sure that this is going to be well received, because I must say, as a clinician, possibly one of the things that worries people more than anything else is about eating needs and the impact on nutrition and general health. So I'm certainly going to be listening to this one with interest. Thanks, Mena. You happy to roll?
Yes, brilliant. I assume that you can see the slides.
I can this time.
Wonderful.
Thank you.
Wonderful. Okay, so good. So far, so good then. Lovely to be here. Thank you so much for the invite. And it's really helpful for me to hear these presentations, because as we'll see in a moment, there's so much crossover between our areas. As you've heard, I'm the national lead for eating disorders based in the Wales Health Collaborative, and I'm going to be talking about Arfid, avoidant restrictive food intake disorder, which some of you may have heard of, but I assume that some may not. So I'll just go through some of the basics, but give you a bit of an outline about where we are generally in the literature and development of services for people who have Arfid. So the context that we're working in here and some of the challenges that we're facing is that it's increasingly acknowledged that there is a gap in services for children and young people who have Arfid or suspected Arfid. We don't have good systems and processes in place to help people identify whether their eating issues are Arfid, to go through a systematic assessment process and to access treatment. It's very patchy. Referrals are inconsistently made to a wide range of services. So what that means is people who have Arfid difficulties can end up in a range of different services and have different experiences. They might end up in children and young people's community eating disorder services, or in generic CAMS, or in community paediatrician services, acute PED services, neurodevelopmental services, dietetic, speech and language services, because it is a complex condition. So it depends on who's the person who first identifies that there is a problem, that they tend to go off on that pathway then, rather than having a coherent system. And unfortunately, people are often turned away from services as they don't fit into the services criteria as they exist at the moment. And many receive inconsistent or inadequate care due to the specific combination of different mental and physical health needs of this group. So at the moment, services don't quite know where to position themselves with these people and how to help them the best. So sometimes people end up with no support at all. So what does Arfid mean? As I say, it stands for Avoidant Restrictive Food Intake Disorder. In the latest version of DSM, it's defined as an eating or feeding disturbance with failure to meet nutritional or energy needs. So that means that somebody is malnourished or not having enough food intake. And this leads to at least one of the following problems. So there's maybe significant weight loss or failure to gain weight in children. There might be significant nutritional deficiency. This might lead to a dependence on alternative feeding. So where there is a long-term dependence on needing NG feeding, tube feeding, or dependence on supplement drinks, that's an indicator that there might be an Arfid issue. And there might be a significant interference with psychosocial functioning. So to have a diagnosis of Arfid, there needs to be at least one of these indicators of disruption to physical or social health. When looking at diagnosing Arfid, we have to rule out a lot of other possible causes for these problems. So Arfid is not caused by concerns about body weight or shape. And this is what sets it apart from other types of eating disorders, such as anorexia or bulimia, or even binge eating difficulties, is that the weight loss or the nutritional problems are caused by other issues that I'll come on to now. And it's not caused by unavailability of food, so it's not because there's not enough food around. It's not caused by any medical condition, not caused by taking substances or medications that might disrupt appetite or interest in food, and it's not caused by another mental disorder. So those are the issues that need to be ruled out as part of the assessment process. So what can cause Arfid? And when we look more in detail into Arfid, it actually breaks down into 3 different types of conditions, which in themselves are distinct. So these are 3 subcategories of Arfid, and keeping these in mind can help to reduce some of the confusion that people sometimes experience around Arfid. So it can firstly be caused by a distress or intolerance around sensory issues with food. Most often, that's because of problems with tolerating textures. A lot of people who have these sensory difficulties with food struggle to manage eating different textures at the same time. So they might be okay with lumpy food and okay with liquid food, but if you have a food that has liquid and lumps all at the same time, that's really difficult to tolerate and handle and to eat. For example, lumpy soup, vegetable soup, or baked beans, or something that has that combination of textures. But also it can extend to particular tastes, particular smells, particular colours, especially strong taste, strong smells, strong colours. So that's one type of Arfid, is the sensory issue type. The second type is more anxiety driven, where there's anxiety about the consequences of eating. And this is a type of health anxiety, if you like. So it might be a fear of particular foods leading to vomiting, or a fear that eating particular foods might lead to having diarrhea or other gastric problems. So people exclude certain types of food because they're worried that those foods will have this particular effect on them. And as time goes on, they might exclude more and more and more foods in order to avoid this result. So people end up eating a very narrow range of foods that they consider safe. So that's type number 2. And then the third type is where people have a long-standing, very low interest in food and eating. They've never been interested in food. Food is a chore, eating is a burden, it gets in the way of life. So people just don't follow a healthy eating pattern as a result. So Arfid is a new term, which has been discussed a lot at the moment, but it's not a new disorder. It's not something that we've just invented, but it's a useful term that brings together a type of issue that historically has been called a lot of different things. It's been called food avoidance, emotional disorder, food phobia, sensory food aversions, choking phobia, food refusal, infantile anorexia. So it just brings all of those descriptions together into more of a coherent way of understanding what's happening. And Arfid does have common features with a number of other issues. It has common features with anorexia in the sense that there is some concern or fear about eating sometimes. There are overlaps with attention deficit hyperactivity disorder in the sense that it can be driven by level of arousal or interest-based avoidance, so avoiding food because of lack of interest and focus of attention being elsewhere and just forgetting to eat. And thirdly, there is an overlap with autism spectrum disorder because of the potential sensory side. But not everyone with Arfid has those sensory issues, but when those issues are there, they are very powerful. In existing child and adolescent eating disorder services, around 13 to 29%, we think, of children meet criteria for Arfid. And in these settings, young people with Arfid appear demographically and clinically different from other children who have anorexia or bulimia. The difficulties tend to be longer in duration. The children tend to be younger than those who have anorexia or bulimia, and they tend to be more males who experience Arfid compared with other types of eating disorders. And weight findings might vary, whereas we tend to think of anorexia and bulimia and binge eating disorders as fitting into certain type of weight presentations. Arfid can happen across the whole range of weight. People with Arfid can be low weight, they can be healthy weight, or they can be overweight, and yet they can still be very severely malnourished. And this can be a real challenge for services, particularly adult services, but maybe children's services as well, where the tier structure of services is based on level of severity. And the service, therefore, needs to be very tuned in to how severely unwell somebody is from a malnutrition point of view, as well as from a weight and other physical issues point of view. And indeed, in the adult eating disorder service that I was working in for a number of years, a couple of the most unwell people we had were actually in the healthy weight range or above, but had some very unusual problems with malnutrition, very severe problems with malnutrition because of the types of food they were eating. So there's likely co-occurring conditions, as I said, with a range of issues that have to be considered co-occurring with Arfid. One of the issues that we're aware of that contributes to the development and maintenance of Arfid is rigidity. And this might be caused by a combination of different issues, as we see here. Rigid thinking might be caused by anxiety, or it might be caused by the effects of trauma, or it might be due to temperament. And this leads to a situation where the person might be quite low novelty seeking. That means, you know, wanting to stick with what's familiar, wanting to stick with what's safe, and avoidance of risk. And this might show itself in many different ways in their lives, but in particular, it will result in health problems when applied to eating pattern. Now, the evidence base for treatments is really in its infancy. There are pilots happening, there are service pathways tentatively being set up, but there is no gold standard at the moment. It's very much in development. But there is a general consensus that what is essential is an MDT approach, and that treatment needs to be multimodal. So that a whole team needs to be involved, providing different aspects of expertise. And also the type of treatment that people have needs to be driven by this understanding of what is the underlying cause. Is the Arfid being driven by these sensory issues around food, or is it more of an anxiety, kind of health anxiety, phobia issue, or is it an issue relating to lack of interest around eating? And so the assessment process really needs to dig into that to make that clear for people to have the appropriate approach to treatment. And we need to exercise caution in generalising any findings from treatments across the whole Arfid populations and presentations. So we will find that different things will work for different people. Psychological intervention approaches, including individual, behavioural and CBT interventions, are looking very promising, as well as family-based work to include parental training. So that's the angle that we're working at, which is looking most promising at the moment, which is a combination of behavioural approaches and the family work. And there's a lot of detail on this slide, but maybe if the slides are circulated, if you're interested, you can have a bit of a closer look at it another time. Because some of this will make sense to psychologists and people who do therapy, but not to everyone. But I'm including this slide just to demonstrate that point, that there are different approaches and different things that we think are useful to people according to their individual situation. So there might be a focus around addressing people's routines and daily structure and managing their arousal around eating, if that's the issue. If there's more of a sensory issue, then that will be the target of an intervention. Or if it's about having concerns about aversive consequences of eating, then interventions that we are more familiar with using around anxiety will be used there. And this table has been put together, as you can see on the top, by Rachel Bryant-Waugh, who is one of the leading people in the UK and probably across the world, based in London, developing these ideas and pathways. No idea how I'm doing with time. Just
you're fine, Mena.
Doing okay. One slide left. I lost the clock when I started sharing my slides, so I'm glad I'm doing it all right. So again, we're looking at different modes of intervention. The different modes would focus on psychological interventions, nutritional intervention, medical intervention and sensory management. So these are the four components that we need to have in place. And a little bit more detail around that within the psychological interventions. There might be behavioural types of work, desensitizing people to different types of food, gradually reintroducing foods they've been avoiding, working with parents, working with the whole family to support that. But I think what's really valuable to keep in mind is that when working with somebody who has very significant sensory difficulties or intolerances around particular kinds of foods, that those issues are not going to go away. So the approach to working with people with Arfid is much more taking into account what the difficulties are that they experience with particular kinds of foods and ensuring that they have adequate nutrition and working around those difficulties. Whereas historically, working with somebody with, say, anorexia or bulimia who's avoiding particular kinds of foods, we would really target that avoidance so that by the end of treatment, the person is eating a broad range of foods and ideally not avoiding any kinds of foods and not having any anxieties about any types of foods anymore. It's different with people who have Arfid because we sometimes need to find workarounds. And with the nutritional aspect of treatment, sometimes the Arfid is so prevalent in the types of food that people cannot tolerate to eat that we accept that they might need to have nutritional supplements on a long-term basis. So the treatment then becomes focused on finding out what are the nutritional gaps in the person's pattern of food intake and plugging those gaps with appropriate supplementation and just supporting that on a long-term basis. But where there are areas that people feel that they want to reintroduce a new type of food, then we would support that in a very gradual way. For example, if a young person has real anxiety around eating pizza and that is causing a significant social problem for them because they're not able to socialize with their friends who often go to the pizza restaurant, then we could specifically work with them to gradually introduce a familiarity and ability to eat certain types of pizza so that they're able to engage in that behavior. So it's very targeted work. And the medical interventions around monitoring and ensuring the person is physically safe goes alongside this throughout. And where sensory issues are relevant, that becomes part of the treatment. I think that's everything.
That's great. Thank you, Mena. That was brilliant. So I can see there's some really good discussion going on in the chat bar. I'm going to hand over to Deb in a second because she's been trying to pull together questions. So we've had our first two presentations, very different themes. Certainly within the chat bar, quite a theme coming out about some of the challenges, the sensitivities, the emotions that a lot of this work raises, and some of the challenges and the best ways to sort of manage that and to consider that. So Deb, with the questions, I can see we've got questions in the chat for both Helen and for Mena. Where would you like to kick off?
Yeah, okay. So Mena, if it's okay, we'll kick off with a couple of questions for yourself. And the first one's from Kath, and it's around the Arfid. And if someone has been prescribed supplementary feeding prior to actually getting a referral and they've put on weight and grown as a result, can they still get a diagnosis and finally got a referral to CAMHS after a couple of years under dietitians on Pedisure, but is also finally not underweight?
Yeah, absolutely. So a diagnosis of Arfid should not depend on weight. It's looking at the underlying issues that are contributing to anxiety or actual avoidance around particular foods and focusing on that. Now, changes in weight might occur as a result of that, but Arfid can actually lead to people gaining weight because for many people who have sensory issues around food, the foods that they feel comfortable eating are what we call bland foods. They're white foods. So that can involve a lot of quite high carb, high fat content foods, which can actually contribute to weight gain in many cases. But nutritionally, they're still very malnourished, so it's still a very serious problem. So I hope that fits. Hope that makes sense.
Yes. Anything? I'm just checking that kind of answers the question, Kat.
Yeah, thank you.
Okay. And a second question, if we may, Mena, which is from Leah, Speech and Language in Swansea Bay. I'm wondering if there's been any research around co-occurring food allergies and ASD and the risk factors for Arfid.
I don't know specifically. I'm not aware of it, and I'm guessing probably not, because the research base in Arfid is so early at the moment. I think that's an area that definitely needs to be explored. But I think we're still in the process of working out what it is, how do we assess, how do we support people. So I think that the finer details are yet to be explored, but definitely an important area.
Okay, and final question, Minna, for yourself is more of a discussion, I guess, but it's around the experience that clinicians will have in working with children with autism and significant learning disabilities around Arfid interventions, and any thoughts you may have on that.
Well, I guess what's really crucial is for services to work together, and often this does require a real team effort between eating disorder services and paediatric services and possibly learning disability services as well, really coming together and having a coherent treatment plan. So I think taking it slowly and making sure that people have common goals in place for actually what the expectations are for the outcome of treatment, because I think that's where treatment often becomes really challenging for people with Arfid, is that the expectation of what improvement looks like is quite inappropriate, and frustrations mount up, and people aren't receiving the type of support that's relevant to them. So having all of those services coming together and having those discussions is really key.
Okay, thank you, Minna. And then Kath, in the chat bar, there's been lots of comments around Helen's presentation, and in terms of, they're more comments, I guess, than actual questions. But one of those that may, Helen, you may want to respond to is the kind of comment from Willow, which is, I think it's important to note that an ND child can present with trauma due to sensory impact of their environment, but also there's a huge amount of trauma that can be created by being misunderstood by peers and society. You may want to offer some thoughts on that.
Here. I think the chat, I must say, the chat has been fascinating. It was a short presentation, so we didn't have time to kind of get into that, but there's so many opportunities for vicious and virtuous circles. And, you know, there was a fantastic comment, was a couple of really good comments made about, at the end of the day, it's not the child that's the problem, it's the environment. But it's sometimes very, very difficult for people to work out what the problem is in the environment. I actually had a child with real sensory sensitivities who used to have massive meltdowns in a particular cafe. And it wasn't until she was a few years older she was able to say it was the music that was just utterly intolerable to her. So sometimes you can't work out what it is as a parent. And then you as a parent get very stressed. And I think services, we really have to get our heads around this. We get the direction of causality wrong. We see a parent who's exhausted and their hair isn't brushed and they're a bit mad, and we think that they've caused it. And actually, it's anyone would struggle if a child is experiencing this level of problem. So yeah, there's so much to do, but we've just got to get rid of the parent blaming and realise that parents are the people who are probably going to be best able to work out what it is in the child's environment that's difficult. And then we can all get alongside one another to try and modify things and help.
Thank you. And if I may, one last question for Helen, just making sure we spread it out. And it's coming quite last minute, really, from Freddie, which is around, is there a potential correlation between ACEs, trauma, ND conditions, and being partly leading to a potential misdiagnosis?
Yeah, I think it happens all the time. I think often, I see it often, that a child has, for example, ADHD, but there's also been a history of adversity. And so there are just huge assumptions made that somehow the behaviour has been caused by the trauma. And our research suggests that that is very rarely the case. So yes, I think for children and young people where there's complexity, we need to do our best but our most ordinary assessment and formulation, and not make assumptions.
Deb, can I come in on that one with a query sort of for Helen in that way? Because I heard I heard you speak last week when there was a really interesting collaborative meeting between researchers between Edinburgh University, Bath, Queen's Belfast and Cardiff around specifically neurodiversity at a population level with neurodivergent individuals who'd had looked after experience and in the care system. And there was some very positive discussion there about, yes, this is a complex situation, but let's not panic, let's not give up hope. Let's look at opportunities for research and break it down. And you had some ideas about that. But another point you made as well was, let's look at how somebody's presenting. Let's be mindful of etiology, yes, as part of the formulation, but let's not exclude people because we have preconceived ideas almost. And I think that's still something that we see. Is there anything you'd like to comment on that, really?
I just think we have to realise as clinicians that we unfortunately use stigma. We know, for example, that Black and working class kids often get diagnoses of neurodevelopmental problems late. And we also know that late diagnosis is associated with problems with criminal behaviour and things at a population level. So I think I'm not sure if it was that meeting, but I keep talking about Psychiatry 101. You know, it's not, we don't need to reinvent anything or do anything fancy. We actually do understand the range of difficulties. And it's just a case of being very thorough, especially if somebody's experienced adversity. And don't assume that because they're living in difficult circumstances that's caused everything. Because many people living in difficult circumstances are resilient. So really for me, the point is just do what we know how to do, but do it with everyone. Just don't jump to conclusions.
Thank you, Helen. And I think that's so relevant to the approach and really part of the theme of today's discussions about how we as a collaborative team want to move this forward and how this has implications for a whole systems approach, because there is that risk of becoming very, very, isolated or siloed around thinking and seeing a child through the lens of whichever recent training you've had, in that sort of way. So thank you, Deb. Were there any other questions that you wanted to put forward before we moved on?
No, what I've done is captured the body of the questions, and we'll give that some thought, Kath, and send that back out alongside the presentations.
That'd be excellent, so that we can build that discussion. So thank you so much to both Helen and Mena for those lovely presentations. We're going to move now on to a presentation by Dr. Annie Proctor. Now, I've known Annie for many years. Her clinical background is in paediatrics and specialising in genetics. And for a number of years now, she's been the clinical board director for mental health services in Cardiff and Vale. She's presenting alongside Professor James Walters, who's director of the MRC in Cardiff, with lead for neuropsychiatry, genetics and genomic research. So I'm very delighted to welcome them to come and present to us around the development of a mental health genetic service.
Thank you, Kath. Can you hear me all right? I've got a new headset on, which I'm not entirely confident about. Is that all right?
I can, and I hope everybody else can.
Excellent. And I hope James is out there somewhere, is he? He's got the slides. Are you there, James? Don't tell me he hasn't turned up. Are you there?
We are running a little moment early because I know he was at a previous meeting, was joining us, wasn't he?
That's right. So hopefully, okay. I mean, what I might do is just before he never waste a moment to rabbit on. I mean, one of the interesting things about this research is that, as Kath said, we go back a long way together, and although we both look 21, obviously, and my background is in paediatrics, and particularly in what was community paediatrics at the time, which is where Kath and I came across each other. Since trained as a clinical geneticist, and now I've had the pleasure of working with mental health services for the last 8 years. One thing I would do is just apologise ahead of time, is just listening to your talk. I'm not sure that in the world I work, we're quite sophisticated in terms of the language we use. So it's been really interesting in hearing you talk about, all makes huge sense to me, but around neurodevelopmental differences and neurodiversity as opposed to a neurodevelopmental disorder. So I just want to get an apology, and first of all, if we use any language that isn't something that you're used to using or that you would prefer, just to apologise ahead of time and put it down to us needing educating, because at the moment, particularly my mental health, James and I both work very much in an adult orientated world, but we do work with young people and young adults. So, and James in particular works with first episode psychosis, where we're seeing a lot of people with neurodevelopmental diversity who have had all the challenges that you've been talking so eloquently about. So it's been, thank you very much. I've really enjoyed listening to all the comments in the chat in the sidebar, because you never come to a meeting like this and not learn something. So I just wanted to put an apology and thanks there. Still has, I can busk for a little while, but not that long. The other thing to say, I suppose, is that the talk we're going to give is about an embryonic service that's just developing now, and the aim of this is to deliver it in an all Wales way, so that if there's any impression that this is Cardiff based or Cardiff centric, it absolutely isn't. And I was clinical director myself of the All Wales Medical Genetics Service for about 10 years, so absolutely have an All Wales remit. He's trying to get into Teams. He's saying he's struggling.
Annapurna, can you see him in the waiting room?
I'll resend the link. Yeah, give me 1 second.
Okay. Because one of the things that we've been asked, we've discussed it at the Genomics Partnership Wales, and there are a lot of, oh, there he is, service users on that committee. And I just want to reassure people that this has an all Wales, because I can see colleagues here from Hywel Dda and Swansea. This is not about Cardiff. This is about an all Wales. I've been busking James for about 5 minutes, so.
Well, I'm not late yet. It's just gone 25 minutes. Sorry, everyone. I had to reload Teams. I apologise.
Are you able to load the slides now, James?
I am.
Because I can't make up anything else to say.
Annie, James owes you.
He does. Yeah, I'll make sure he pays. So he's going to move the slides on, hopefully. Okay, lovely. So you know who I am because I've gabbled on for a little while, and James is my colleague, and I have to say it's been an absolute joy working with him, and between us we've been able to develop this service, which is embryonic, but we hope to move it on at pace given the opportunity. So next slide, please, James. So what I'm hoping to do is sort of gallop through this a little bit, is to set the scene and to talk about access to mental health services and sort of mainstream versus rare conditions in mental health, using schizophrenia as a paradigm, but certainly looking more at neurodevelopmental diversity and differences and how genetics might play a role in that. It was really interesting to hear Helen mention that in her talk. Just talk about what we're doing in Wales and how we hope to move that on into the future. So next slide. And I think, so this is one of those unusual situations where I, as a geneticist, are going to talk about mental health, and James, as a psychiatrist, is going to talk about genetics. And this is one of the lovely things about the work we've been doing here, is there's massive crossover between services and between disciplines, which I think is a huge strength. And as you've seen in the chat bar, with service users and carers and families and parents and young people, we can move this stuff on, and it's really important. Next slide, please. I was really struck by what the slide that Helen put in as well, which is the bigger the load, the bigger the risk. And the important thing about what we're going to talk about this morning is that for some individuals, their genetic risk makes that load even harder to carry. So this is about vulnerability and reduced resilience. So if your genetic makeup makes you vulnerable, then your ability to carry that bigger load, whether it just be normal life or whether it be ACEs and trauma, your ability to deal with life is that much more reduced. And that's, I think, the way to look at this, not to think necessarily about diagnostics, but to think about it as a vulnerability and a risk. We've talked a lot to service users about this, both to young people through our partnership board and to the adult and older adults. And service users are asking us for access. In other areas of healthcare, if you've got a physical health problem, you can get access to genomic advice and information. And why aren't we doing that for people with mental health challenges? And this is our aim, is to try and redress that balance. Next slide, please. Coming from a background in genetics, I know that in the old days, sort of cancer was the dirty word. Now kind of mental health challenges are the thing that we struggle with. And we do know that people with genetic disorders have mental health challenges, and that actually professionals who are working in genetic services need a lot of help and support to both talk about mental ill health and mental health challenges, both for people who have severe and enduring mental illness and people who have neurodevelopmental differences. But we need help to direct those people into services. We don't necessarily know where to refer them. Next slide, please. And similarly, having worked in mental health now for 8 years, I know that our ability in mental health services to talk about genetic risk is pretty poor, and we need, despite having sort of world-class research going on in Cardiff, we have not moved this into service delivery, which is what we want to do, because as you will all know better than I do, that if we can focus people early, if we can identify those whose risk is higher, who might benefit from early treatment, then we know that their outcomes are likely to be better. And this is hugely important. You're seeing children whom, if we could support early on, and I love this idea of a needs-based assessment and language around strength. If we can get in there early, we know that adults, particularly affected by schizophrenia, for example, are likely to have poorer outcomes and die 20 years earlier than their peers. And this is an opportunity for a group of individuals to do something about that. Next slide. This is one of the things that you were talking about earlier, Helen, I know, talking about looking at those young people with depression and that actually their cardiovascular health was much poorer. And we see this in adult mental health services all the time, that people who have mental health challenges, I know this audience are no stranger to this, but people who have mental health challenges, their physical health and their quality of life is likely to be poorer than their peers. And what we are aiming with this service that we're rolling out is for a group of these individuals where we can identify that their risk is higher. We have an opportunity, particularly probably around physical health, but certainly in a holistic approach to improve their quality of life. Next slide. I would also say I've already been asked by psychiatrists, is this a eugenics approach? Are we basically looking to terminate people with genetic disorders? Are you going to do DNA testing in everybody? Absolutely not. This is about a cautious MDT approach with the input of families and service users and young people at every step of the way. But it's about improving the quality of the conversation, both generally, but particularly in mental health services and in genetic services, about that overlap of individuals who are at risk because of their genetic profile. Next slide. So what are we hoping to do? The joy of being a geneticist is you see people of all ages, from actually when they're still in the womb right through to later life. And it's one of the things I particularly value. But one of our key aims for this service, and you'll see across the top there, the people who are involved in this, is we are hoping to translate high quality genetic research into service delivery, and particularly interested in the area of prevention and early intervention in terms particularly probably of physical ill health, but also in terms of mental health and development. And another area that we're very keen on is education and training. It's not about delivering everything from one central clinic. It's about supporting professionals to have high quality conversations about difficult stuff with families. Next slide. The little bit of history of this is I already mentioned the fact that there is this high quality research going on in Wales, but also there's the All Wales Medical Genomics Service, which has an All Wales remit. So these are two very obvious stakeholders in this venture. Back in 2014, we got together a group of people to meet every other month to think about genetic diagnoses in individuals and families with mental health challenges, and it's a very vibrant, multicultural, if you like, in terms of the people who come along, in terms of their professional interests and their experience and their background, and it's a fantastic sort of melting pot and opportunity to talk about how we might do things better for some of these individuals. From that, we then started the Psychiatric Genetic Clinic, which is delivered at the moment by James and I, but we're hoping to have a genetic counsellor in there fairly soon, whose role will be both to deliver genetic counselling, but also to upskill, educate and train people across Wales, so that we, and I know it as, you know, and as you will know it very well, as a clinical geneticist sitting in a clinic with a young person with a genetic diagnosis and not knowing which way to turn for support. Next slide. And I suppose this has been one of the other joys of this is the MDT nature of the growth of this idea, which we're now translating into a service. And it's involved people from an academic background, mental health, genetics, but most particularly we talk to families, service users, carers and our frontline staff. And this is a moment in time, I think, where the opportunities presented by genomics are sitting there waiting for us to translate into service delivery. So I'm going to hand over to James now, I think, who's going to take us on and talk about the genetic side of it just a little bit more. Oh, he's frozen.
Hello, can you hear me?
Yes, you're back now. I don't know who froze, somebody did.
Okay, sorry. Thank you, Annie, and thanks to the organisers. I think it's really pleasing to speak to everyone today. I just wanted to stress from the outset that this development has really relied upon all of these elements. So, as Annie said, building on some of the research that we've accomplished over the last 10 years, but actually crucially bringing together mental health services and NHS genetics services with that work. And Annie has been described by others as a unicorn in that she's unique with these bridging skills across mental health and clinical genetics. And certainly, these developments wouldn't have been possible without us being fortuitous to have somebody in those positions, I think. So I'm James Walters. I'm the director of the Medical Research Council Centre for Neuropsychiatric Genetics and Genomics, and we're based here in the centre of Cardiff. And I also work in the National Centre for Mental Health. So this is a Welsh Government funded body to do mental health research and educate, as well as collect a big cohort of people for our research studies. And what I'm going to do is tell you why we do genetics research, really. And my main area of interest is schizophrenia, but I think the lessons from schizophrenia have got wider application, and I'll talk to you about some of the major findings in that area. So if we want to find out more about mental health conditions, neurodevelopmental diversity, then it's hard, is the first thing to say. So unlike medical disorders like liver disease or heart disease, we can't access the organ that is incriminated in a lot of what happens, and so we can't get ready access to the brain to take tissue samples, understand. We can image it, and imaging is advancing all the time, but still is quite rudimentary, to be honest. And so genetics gives us a route in, because genes are the things that produce proteins and can determine the ways our body functions. And so we think that's a good route into getting insights into the underlying biology of some of the conditions and outcomes that we want to look at. It's also, from a scientific point of view, easier because it isn't subject to some of the confounders that other approaches are. So somebody's medication that they've taken might influence their imaging findings, but it doesn't influence their underlying genetics. And so that makes interpretation slightly easier. What I would say is that there's a real burgeoning area in using genetics alongside non-genetic risk, so what we call environmental risk, but that might be to do with somebody's birth, upbringing, drugs, or whatever. And I think because we're studying genetics doesn't mean we don't think those other things are important. It's just that genetics gives us a ready route in. And it hopefully will also help us improve our diagnostic and classification systems, because we know they're really imperfect and can be a barrier a lot of the time. Okay, and the other reason we want to use genetics is because the conditions that we typically study, and schizophrenia is given as the example here, are heritable. So genetics makes a substantial contribution to the difference we see in the rates of these conditions across the population. And so, you know, again, if you're going to use genetics to study a condition, then you want it to be heritable. And the other thing is that there have been real technological advances that I'll come on to talk about how we run genetic experiments. And certainly, you know, in the last 10 years, we've learned more about the genetics of humans and of the way we function than we have in the 100 years previous to that, which is really exciting. And this is some of that technology. So what we can do is use one of these called a genotyping array, and on that array, you can run, look at the genetic variation for 100 people across 1 million different variants for each people, and that would have taken months and months to do, even, you know, 5-10 years ago. But now that can be done, you know, in a matter of days, and that allows us to look at these common changes. So these are changes that we all carry. So, you know, somebody might have a CG here and somebody else might have a TA at the same position. So these are called single nucleotide polymorphisms, and we all have got them. They typically occur in over 5% of the population. And we bring those together in what are called genome-wide association studies. And that, when we compare people with or without the condition, or for their either height or whatever, allows us to assign the alleles, the variants that increase risk or increase your height, or whatever outcome that you're looking at. And then similarly, we can also use these arrays to look at what are called copy number variants. So these are large bits of DNA that are either deleted. So here you can see that the middle person's chromosomes have a C and a C, but on the deletion, that C block of the chromosome is deleted or duplicated, in that this person's got an extra copy of the C chromosome. And this has implications for the proteins that are produced from those genes typically. And we know quite a bit about how these copy number variants may influence risk. And then more recently, so these arrays look at representative changes across the genome, but actually what we've started to do is look at every base pair. So instead of looking at this and maybe 100 base pairs down, we look at every single base pair, and that's called sequencing. And whole exome sequencing looks at the bit of the genome that produces proteins, and then there's also now whole genome sequencing. And I think you may have heard a lot about this already, but you will increasingly in the next 5 or 10 years, because the NHS is rolling out big programs to undertake those analyses, and particularly for rare disorders, but also more commonly now as well. And the other thing to say is that genetic risk is exactly as Annie said. It's risk. It doesn't mean if you carry, you know, a whole host of these variants that you're going to get a condition. And I think that's a really important point. There are plenty of people walking around in the population who carry copy number variants but don't have a neurodevelopmental disorder or any diversity. It doesn't impact them to a large extent. So these aren't deterministic at all, which is also why they're no good for the eugenic reasons that Annie said. But that doesn't stop some charlatans trying to promote them in that sense, unfortunately. And the other thing to say is that it's neither one nor the other. So we know that in schizophrenia, for example, for people with copy number variants, they increase risk of somebody developing schizophrenia. But actually those that do develop schizophrenia also carry more of these common variants as a risk for the disorder as well. So it's typically across this range of risk variant frequencies that we see elevated risk. And we've applied these methods really successfully, identifying regions of the genome that increase risk. And one of the reasons to do that is to then try and develop better treatments based on this information. And so schizophrenia has been the poster child in many respects. And now myself and Mick O'Donovan, my colleague, lead an international consortium that brings together about 75,000 people with schizophrenia and their data, and we've now found close to 300 regions of the genome that are helping us identify the underlying biology. And similarly, there have been advances in this sense in other neurodevelopmental disorders or in neurodevelopmental diversity in population studies. What you can do then is look across somebody's whole genome and say how many of the different risk variants they've got, essentially. And, you know, we will all lie somewhere on this distribution. So somebody might have, and there are thousands of these risk variants. So somebody might carry 300, somebody might carry 500, somebody might carry thousands, and we all lie across here. And how many we carry essentially goes to make our polygenic risks or polygenic score for a given outcome. And you may have seen these spoken about in helping predict people's risk of cardiovascular disease, and similarly has happened with psychiatric disorders. So in coronary artery disease, the big play was made that if you take the people who score in the top 1% of these polygenic risk scores, then their risk of getting a coronary artery condition is about 5-fold increased. And we did the same for that with schizophrenia. And actually, if you lie at the top end of that distribution, then your risk is even more increased of having the condition, about 6 to 7-fold increased. But the crucial thing being, and you can now go on 23andMe and other websites, and they will do your schizophrenia polygenic risk for you. But actually, it's virtually useless to do that for people in the population. And that's a really important message to get across, I think. These things, these advances, which are scientific advances at the moment, aren't yet clinically applicable. There are questions about whether they'll ever be, certainly for the kind of conditions that I treat people for. And so we need to be really cautious about that. Okay, and then a bit more about copy number variants. So the fact that these increased risk for schizophrenia was found out for the first time in the late 80s, and then more recently, so this was the initial finding for a big deletion of 3 million base pairs, typically on chromosome 22, and the increased risk of schizophrenia was really high. So 1 in 4 people carrying this variant seem to develop schizophrenia. Whereas the risk in the population is 1%, so they've got a very elevated risk. And since then, we've also shown that if you've got a duplication, so extra copies across this region, that actually protects you against getting schizophrenia. So this seemed a very important finding, and actually colleagues and I have gone on to show that there are a host of these copy number variants that occur because they're bits of the genome that are susceptible to making mistakes in their replication. And so these happen recurrently, and there are some that increase risk of schizophrenia, but also increase risk of intellectual disability, developmental delay, autism spectrum conditions, and other neurodevelopmental outcomes. And we also know that the bigger the effect of the CMV has, the worse the outcomes for people. And in schizophrenia, particularly, that manifests as cognitive impairment, so people having memory and concentration problems, which are over and above those with the condition, which are substantial anyway. And the other thing, as Annie touched on, is that these aren't only imparting increased risk for mental health, but also for physical health. And so, people who have these copy number variants have increased risk of the kind of conditions that lead to that increased mortality for those with severe mental illnesses. And so, we know that we don't do well enough in monitoring these kind of conditions. And we think that if by introducing the kind of service Annie has described, that we'll be able to identify people at greater risk at an earlier stage and prevent some of these outcomes happening. And so, this brought things together for us. There was these, really exciting research findings in many respects, but we needed to be cautious about their clinical application. And then these developments within the Welsh NHS, and Annie and her colleagues really being enthusiastic about this. And I think this leads to Wales being positioned pretty uniquely in the world, actually, to take this work forward. And the other thing that has always proven important is the support of good people. Kim Kendall's a psychiatric trainee and junior researcher who's been instrumental in this stuff. Sean Morgan leads the labs, and Annie has brought us all together to advance this. So I'm very pleased to be part of that and look forward to people's questions. But before that, I'm just going to hand back to Annie.
So just to, I suppose, tie this up together, and I suspect this audience don't need convincing of this, but it's the so what question. And if you've got a young man there in the centre with his mother, how could DNA genetic testing or genetic conversations help him? And this is, to use that word, it's about empowerment and about information. It's also about the stuff you've all been talking about, which is getting, society isn't built well for people with particular needs and who are different. And so there's something about this, if we can help to identify a group of people in whom prevention and early intervention would be useful and help them with their choices and their decision making, we can really make an impact on them. I feel very passionately about this at any point during their lives, and help them across the board with their quality of life and their personal outcomes. And I think it's not just about one age group, it is actually across the age spectrum, and it is all about families, because your DNA isn't your own. You share it with your ancestors and your descendants. Next slide. So really that was just, it's been a great pleasure to have the opportunity to present it all. I've seen some fantastic questions going up the side, and we'll help and provide answers if we can.
Thank you, Annie. Thank you, James. That was brilliant. And I think it really reflects on why we've got such a range of presenters and speakers today, that we are looking at that whole system approach and how there are so many different components within quite a complex system. But thank you particularly, for your discussion about the work that is ongoing about clinical significance, that difference between risk and determinism in that way. So that was brilliant. Thank you. So Deb, I know you've been working furiously collating questions. Are you ready to go on those? We've got a few minutes before our comfort break.
I am. Any nervousness about the lack of questions quickly faded, so I'll do my best to get through as many as I can. So if we start at the bottom and work up, I guess, and we start with an observation and a question, which is from Kerry Reed, which is this why neurodiversity within families can be variable?
Spot on. Yeah, saw that and thought there's somebody who's been listening. Yeah, absolutely spot on. Yeah.
Okay, and then from Anne-Marie McKinley, in terms of costs, genetic testing was previously considered too costly. Have costs decreased, and how widely will the testing be offered or decided?
So I think sorry, I'll just dip in first with
sure.
the general genetic testing costs. Yes, they have gone down. One of the challenges with this is that the sophistication of the tests has gone up, and actually the amount of information we can get from doing a genetic test is huge. The difficulty with it is interpreting it. And in terms of our clinical interpretation, James touched on it and might say a bit more about the polygenic risk. It's how do you decide how if you get an 8% risk, let's say, of diabetes, what does that even mean? And can you do anything about that? And that's even more difficult when it relates to mental health resilience and mental well-being and that kind of thing. So tests have gone down in price, but I actually think that's more of a challenge than a benefit in some areas, because our ability to understand. If I just say one more thing, when I came into genetics, we all thought that if you had something in your DNA, you were very unusual. We now know that we've all got massive changes across our DNA, across our thousands of genes, and it's trying to interpret which ones of those are going to cause problems or not. So it's not as easy as it sounds. Sorry, James, I chipped right in there.
No, I completely agree. I think it's not much more expensive to get your genome done now than it is to get a whole host of other blood tests. But as Annie says, that's only the start of it. And actually, you know, the clinic that we've organised together has mostly been about having conversations with people and families, and we thought that people would request tests much more than they've actually ended up doing, because the conversation has really helped them understand. And I think a lot of this is about, you know, enhancing understanding. So the tests are cheap now, to be honest. They're much cheaper than having a scan or something like that. But it's the support around those tests. And part of the service that I'm trying to develop is about educating other health professionals, to be honest, because, you know, a lot of people working in mental health or peds or in other branches of medicine don't themselves know a lot about this genetic risk, but also how to communicate and support families in that sense. And the model of how we do that still is uncertain. We're relying upon the expertise of genetic counsellors, and I think that's key. But if it's going to be larger scale, then we need to think about newer models as well.
Okay, thank you. Following up with that is a question from Sunny from Cyntaf Maganwg, which is very similar to a question we had earlier on, which is around our appetite to potentially avoid wrong diagnosis, and how can we facilitate to fasten the testing in order to avoid this?
Yeah, and it's interesting that you've picked FASD as an example. I mean, for some of these dysmorphic diagnoses, you know, there isn't yet a test. And actually, when we've developed tests in people with particular diagnoses, it's always dysmorphic syndromes, if you like. It's got much more difficult because you might describe it like that, but the testing gives you that many differences. I still think personally that it comes down to looking at the child and talking to the family, thinking particularly about children and young people, and a test should actually almost be, in some cases, backing. If you're doing a proper needs-based assessment, whatever your genetic diagnosis is, you should be able to get what you need. And I think for some of these syndromes, it's going to be a long time before we get a genetic test result, because you're always talking about vulnerability and risk, and then you're adding in experience. And I think experience sometimes, well, for me as a geneticist, often will trump your genetic makeup. So I don't know if I've answered that very well, but I think it's, for me, if you have a proper high quality conversation, and we're working with partners like Cerebra to look at how we can develop information for families particularly, and for professionals, so that when a child has a particular group of needs, whatever their genetics says or whatever the label on the diagnosis thing says, they get what they need. And so that would be my view. Yeah.
Okay, thank you. Another couple of questions, if we can, and if time allows. Willow's raised a question, I guess, and probably a concern, which is around the interface between genetic testing and autism. And
in terms of
that many factors go unidentified, so there's a lack of appetite to test.
Oh, I see. Yeah. Well, I think it's a challenge. I think listening to you earlier, this is and what Kath's introduction is, this massive diversity. I think what we're anxious about is doing a test and getting somebody labelled as something which actually may not be correct. And it's about a constellation, putting together a constellation, a description, if you like, which then gives people access to what they need. I think it is going to be a long time before we sort that out, but we'll only get there by talking to families and young people themselves. I think. I don't think it's very easy, and I completely take your point. Yeah.
And on the access to testing front, I mean, that's exactly why we've started this service, is to try and educate people so that those tests in an appropriate environment can be supported, I think.
But should never be without the conversation, I think, because I think sometimes the expectation around testing is challenging, and I don't think anyone should have a DNA test without the opportunity to talk about what that means for them and their families, because as I said, you don't own your own DNA.
Absolutely.
Okay, thank you.
I just didn't want to let one question go unanswered, which is somebody said about a huge gap in support when it comes to genetics. So this is Kath, and I think it's a really important point. Yeah. So the service, what we've learned is there are two issues really. There's people who come to mental health services, and there's very little consideration of genetics within those patients. But then there are also people who've had a genetic test and been told that they have a genetic risk, but that serves as a barrier actually to those people getting access to services
Absolutely.
and assessment. And so that again is something that we think with education we'll hopefully be able to get right. But services just aren't designed in a way to support people as those cats as described. So that in psychosis, for instance, there are support services for people that might be at risk of psychosis defined by symptoms, if you like. But actually, the risk for some of the people in these categories is much higher than that, and it's wrong that those people aren't getting the similar services. So that is something we're working to address, actually. But it's a long game. But I think if we can do it, if we can make that case together, it's more likely to be successful, actually.
Brilliant. Thank you, James. Thank you, Annie, for fielding some really constructive questions and answers there. And what we're going to do now, everybody, is have a short comfort break to allow everybody to grab a drink of their preference, stretch their legs. We want to resume as close to 11:20 as we can. During the comfort break, we're going to hopefully be playing on a repeat loop the slides, the poster slides from colleagues. And please have a look at these, see if there's something that catches your interest, something you'd like to link it in with people, because one of the opportunities from this morning is continued collaboration and opportunities to extend the discussions even further. So looking forward to seeing everybody at close to 11:20. If you want to turn off your cameras and mics just for the moment, and we'll see you shortly. Thank you. Right, hoping everybody's in a position to rejoin us. Thank you to everybody who contributed to those posters, to Leah and Shirley over in Swansea Bay, the National Autism team, to Miriam up in Cwmtaff and Aisha in Aneurin Bevan. Really beautiful posters. Thank you for the effort that you put into those. And it's really part of this theme of trying to take forward collaborative work across Wales on lots of different areas of interest, because I'm sure all of you agree there's so many opportunities here. But this is all today about bringing things together for a whole system approach and looking at the practicalities. So moving on, I'm delighted to welcome Kerry Reed. Kerry's the founder, member and organiser of Parents' Voices Wales, and she's here to talk to us about A Parent's Wish. Thank you, Kerry.
Thank you so much, Kath, and thank you for allowing me to speak today. I'm so delighted, but I have to, before I start, I have to say, I don't know about anybody else, but I'm reeling from the previous speakers. And for me, as a parent who's gone through the process of identifying a child early on with sensory gag reflex and speech and language problems, and they're not quite fitting in school, and a bit of bullying and not achieving potential, and it all seems to be that it was premeditated by genes. and you start to think that in the current outcomes are perhaps predictable with our current environment and our policies and pathways. So I've put all the jigsaw pieces, and my synapses are all firing at the moment with my patterns and links in my own brain about how this actually fits in for families. And we know that 70% of our families are neurodiverse, and many of us don't know we're neurodiverse until our children are actually diagnosed neurodiverse. And we also know that 60% of children entering CAMS are neurodiverse. So thank you ever so much for everyone today. It's just put everything into context. So next slide then, thanks, Anne and Perna. Okay, so looking at A Parent's Wish, we wanted to look at first concerns and how parents feel when they're raising a child, and then something's just not quite right, that they're expected, then they have those concerns. And what parents have fed back to me is that they want, when they have those first concerns about whether a child doesn't sit up early enough or doesn't crawl, or they have concerns about any form of development, they want to be able to have some information about not to pacify and say every child develops at a different stage, but to feel informed, to see some evidence for that. Because when you have a concern early on about a child who's possibly neurodiverse, and you may not know at that stage that they're neurodiverse, those concerns never leave. And it wasn't until my son was about 10 that actually I was proved that those concerns were right, that I was right to be concerned. So what parents have asked is, could they have some information on first concerns, when to be concerned? So if a child isn't doing X, Y, and Z by a certain age, and to provide resources for universal support for neurodiverse children and toddlers in the early years, so that we can support that language development, that we can help them with their coordination and the diet, and so that we feel that we're at least doing something, because without those skills, we are solely unempowered and reliant on services to identify those issues early. So parenting, having classes on dealing with emotional dysregulation, making sure that our homes are in a low arousal state, rather than a child who may be oppositional and shouting at them to do what we want them to do, not knowing that actually that oppositional behaviour may be a neurodiverse. So having inclusive and holistic parenting classes early on. When we have our observations, to feed those back to school, and for school to accept those issues that we've, and to monitor it themselves as well, and to feed back to us regularly on how they feel that development of that child is progressing. And when we do know, for example, that a child is ND, and obviously sometimes it's more obvious for some children than others, that we do have practical information that we can support those at school, and how that support needs to change and be framed through the development stages of their age. So whether that be social or coordination or language. And for schools to allow parents and services, obviously, to see us as equal partners, so that we are tracking their development at home and they are tracking their development through services and education, so that the tracking of a child is coming from all perspectives. So when we talked to our parents about holistic or specialist support, I had to explain about early help and how can we move away from labels, and that if we were given those tools to support our children early on with language and diet and socialising and all those other neurodiverse characteristics, would there be any need to have specialist services, diagnostic of you know, I'm not talking about more severe neurodiversity, I'm not talking about the medication of ADHD, but we're talking about other neurodiverse aspects. And parents were quite keen to be reassured that universal support would be given earlier on, but with a, I suppose, a favour that that graduated response would kick in should they feel that from their observations and the tracking in the school that wasn't adequate. And they also wanted to ask about interventions and what would that look like in the short term, what would that look like in the long term, and as their child developed through education and social environments, would that support be accessible at any time, and would they be able to drop in? So that was really interesting. Parents raised concerns about children being identified as neurodiverse or requiring support in school based on their attainment. And as we know, many neurodiverse learners actually will achieve normal academic abilities and attainments. But there are issues that parents raise about their expectations of that attainment versus what they've actually attained. And if they're on a kind of, I suppose, what they call a low normal on the bell curve, is that actually an expected attainment? And I think that sometimes there needs to be some realization that depending on the upbringing of that child and the genetics of that child, of whether actually the attainment they've achieved is accurate. Emotional well-being, parents are saying, you know, if the child is reporting bullying or distress and there's school refusal and oppositional behaviours and their attainment may be okay, should we as well be looking at the red flags? And also if there's a parent or a sibling with neurodiversity, should services and schools be aware of that, and so that child is tracked automatically because they are an at-risk or a possible learner of concern. Next slide, please. So we asked, what would your wish be for neurodiversity in education, and parents reported they would want to see whole school training on neurodiversity. They would want teachers and services to understand that there are child development delays, especially in things like ADHD, where there can be a 25% behind their chronological age, and often this can present in primary schools with children with neurodiversity being on the bottom groups or the bottom table, and understanding that neurodiversity, it isn't about intelligence, you know, this is about child development, cognitive profiles, and that those children will be aware and intellectually aware that they are on the bottom tables, and they're on the bottom tables because of their neurodiversity and not because of their intelligence. So again, that predisposition for the genetics for neurodiversity is impacting already in the environment and outcomes for their mental health and self-esteem. So we want that parents want to move away from ability tables and rewards for attainment. They want their neurodiverse children to be rewarded for effort, because that then is a carrot to keep wanting to learn. Because if you're never going to achieve a reward, obviously, for not being an A-star student, then why bother? You know, so they want their children to be seen as a whole child and to see a strength-based approach, and for their creativity and their different way of thinking to be embraced and encouraged. Parents have asked for neurodiversity training to be part of the initial teacher training, but also in the curriculum in school, because they think that along with sexual health, being aware of neurodiversity and differences, and sometimes the barriers to socialising, which in the teen years can prove difficult for neurodiverse children, that they can become aware of their own differences and they can learn management skills in order to manage those differences, or know when to maybe highlight that to a team and say, look, you know, I'm struggling in this area, could you give me some help? It also bringing neurodiversity is centre into the curriculum and teacher training, along with emotional well-being. It also brings in the pupil voice, doesn't it? So that they're able to tell the school and tell services what they need, and that it can't get much better than that. We're looking at the ALN code, and we're delighted that this ALN code is going to provide universal support and early help. But there are elements to it that obviously, as an organisation, I will be being open to poor Jeremy Miles about what I think needs to happen for neurodiverse learners. So we will be asking for some consideration of flexible timetables, where some children have struggled with morning anxiety and transitions into school, where we kind of do away with the fines for attendance and things like that, because that becomes a them and us and a barrier. And for schools to work as a team for neurodiverse learners. We know that the statements will be phased out from September over a 3-year period, and we'll be working with independent development plans, individual development plans. So that kind of collaboration that we're talking about today needs to happen on the ground in schools as well, as well as services. We need the environments for our neurodiverse learners to be inclusive for all their needs. So could we possibly not make the Welsh language, and I'm sorry if this offends anybody, mandatory for those that have a developmental language delay? Is that really a necessity, and is that being child-centred when we're looking at a well-being of the curriculum? I've done a poll recently with parents about mandatory Welsh language, and we found that the children with neurodiversity and developmental language delay specifically didn't struggle as much in Welsh medium schools because they were immersed in that language regularly, but children in English medium schools, it really did affect their mental health. So when we're talking about curriculum and emotional well-being, we have to look at the big picture. We need our resources for our neurodiverse learners, like iPads for those with dyspraxia, and for many with developmental language disorders and dyspraxia, they will enjoy mind maps as a way of engaging in lessons rather than having, you know, loads and loads of text, especially dyslexia as well. And I know that some secondary schools are now engaging with mind map working, which has been really helpful for my own child, actually. Parents have asked for smaller classes. If we're looking at inclusion, smaller classes and quiet spaces for those with sensory needs to escape if they need to. And for those with ADHD, perhaps standing desks where there can be movement and maybe some sensory breaks. So we're looking as well at, when we come to assessments, we're looking at practical, creative and verbal assessments. Some children with dyspraxia and dyslexia will maybe great verbally, whereas others with ADHD, I'm sorry if I'm being definitive, I don't mean to be, I'm just trying to give examples. With ADHD and developmental language delay may be more better practically or creative. So we want the assessments for exams going forward to be much more inclusive and variable to meet the needs of those children. Next slide, please. We talked about, as I said earlier, the holistic approach and inclusiveness of neurodiversity. But I asked about specialist services particularly, and I think parents felt that if we have that early help and universal support early on, but those children need a graduated response to a diagnosis, they want the schools to be able to obtain that support before the diagnosis is made, because there's that waiting time where nobody knows quite what support needs to be framed. So I think what Kath is presenting today is absolutely fundamental to that, to bring down those barriers. And for the assessment of our children, which I think has been definitely highlighted today, has to be holistic, that they don't fit in one box. you can't bracket children in categories, that they are complex beings, and the assessment, be it early on in school with universal support, or be it for diagnoses, is a holistic assessment and not one that focuses on a single lens, because what you're servicing on one part of the child, you're neglecting in another. So we need to see the whole child. Yes, parents believe that specialist services will be important in prescribing for ADHD medication, but they asked if we are moving to a more community-based, can't this be done in primary care? Can't this have an in-reach services from primary care to work with schools on this? And again, parents have said, look, more support. We need to know what we can do at home. We are beholden to the knowledge of services, and we need to, we want to be equal partners. We want to be able to support. And obviously, the more support that we provide at home, the less onus it is on services as well. I asked about the CAMS, and they've asked for the CAMS and Neurodevelopmental services to work as one team. And I have to say that parents aren't aware of the whole system approach. It's quite a difficult concept, isn't it, for the public to think about, and for parents to be saying this without having that knowledge and experience is I think, fundamental to the need of a move to this collaborative working. So they're asking for CAMS and ND to work together. They're asking for connection for our neurodiverse children, for relationships and trust to be made before intervention, because very often neurodiverse children don't want talking therapy, so there has to be a variety of means how we reach them should the early help and universal support not be adequate, and they do, or in the current environments and systems may be predetermined for poor mental health. How do we reach them in order to give them therapies and coping strategies? So not going into CAMS maybe straight away and expect a face-to-face meeting, but to build a connection and a relationship and trust with a child, a connection before reconnection, I think Karen Treisman has said. So it could be digital, telephone, face-to-face, and home-based, because very often transition to different environments can be very stressful. They've also said that the school nurse would be a useful resource for working with neurodiverse learners, because they can have that one-to-one bespoke relationship and connection, and for that school nurse to be the school liaison between services and education, and actually quite a fundamental, I think, profession. So next slide, please. I asked parents about the labels, the benefit of labels, disorder not difference, not disorder, and we are split. The group is split, so we had 50%, but you have to also remember that their opinions at the moment are based on experience and understanding the concept of a whole system approach, and collaborative working will be, there will be some cynicism because of experience of not getting the support that they need. So 50% of the parents have said that actually they would be happy without a label, and they would be happy because it could be seen as a disadvantage for them in their future employment, and it could be that they lose their own identity, and this 50% that were pro difference not disorder is that they would trust, they would have to know that the schools and services really made neurodiversity inclusive, and it was central to their values and policies, and if that were the case, then yes, they would be happy to submit a label. 29% of our parents said that actually no, they wouldn't be happy because they're worried that the child wouldn't get the support they need. There may be a problem with getting PIP, and I think from the parents that did respond to that many of those parents the children had learning disability. So of course there are different variations of the need of support. So parents with children with more severe neurodiversity and disabilities will be feel more secure with. Of course, that would marry that anyway with having a model that was in between the social and medical model. Parents were concerned about the impact on disability allowance and other support should they not have a label. So there was quite a varied response really. And one thing that I thought was quite interesting, is they were worried that if they did have a label, would they get access to mental health services? Because if you have a label and you say, for example, it's neurodiversity or trauma, and I was thinking about Professor Helen Minnis saying about neurodiversity, neurodiverse children having a higher risk of trauma, will that then be written off and they can't access that? So that was quite interesting. And then could it be used for and against them in the law? And parents also thought that having a label may be useful with the disability law of the United Nations Convention. But of course, you know, that's another whole conversation, isn't it? Next slide, please.
Brilliant. Kerry, thank you. That was a fabulous presentation. You covered a huge amount there. What I would say is, for the purposes of time this morning, we'll keep on rolling, but what I'd like to do is maybe take all the different messages, all the different suggestions, and we'll spend some time working through that as part of the program's work, because I know you're representing a big group of parents. So thank you so much for a brilliant presentation. We're going to move straight on now to Christy. Christy is the Patient Experience Manager for Betsy Cadwallader, and she's going to present now on connecting through stories.
Thanks very much for that, Kath. If it's all right, Anna, if I could have my slides up, please. So I just want to start off by saying thanks very much to Dr. Kath and to Deb and the team for letting me speak with you all today. And it was great to hear from Kerry, because I feel like that is such a true reflection of a lot of what I hear as well in North Wales. And so much of it really has hit home with me about how big and how shared some of these experiences are. So as Kath said, my name is Christy Hoskins. And my role is actually one of the first dedicated roles in patient experience that supports children and families. And one of my key areas and something that I'm really, really passionate about is about ensuring that children and young people and their families' experiences are central to how we design and develop our systems. So to think about this today, I wanted to talk about it in terms of how we could potentially do this through storytelling. And since I've begun my role, I've heard so many stories from families, children, young people, from professionals in our internal teams, and from professional partners organisations. And often these stories talk about some of the amazing work that goes on around neurodevelopment, but also they talk about a number of the challenges that exist and the impact that those challenges can have on children and young people and their families. And I know probably every single person in this room has shared my experience. We could probably all tell each other 100 stories about the children and young people here in Wales and what they're experiencing at the moment, either through successes or failures. And I'm sure we've all shared these stories in different arenas and advocated that we build on some of these successes that we hear about and do something about the challenges. I know this because I've been part of a number of storytelling forums, and the National Steering Group itself is part of this forum. And I always notice at every meeting, there's a new story shared about something new and innovative that's going on in neurodiversity. And also that the challenges are regularly shared and presented there. But the reason I really wanted to speak today is I want to find a way to build on all of our shared experiences and to capture the stories that I hear, not only here in North Wales, but I hear in forums like this one, and to use that to support some of the innovative work that's already begun in this forum, bringing together the stories from children and young people and their families, together with those from professionals across the system, to develop a detailed and compelling evidence base that will allow us to create ongoing, highly informed opportunities for co-production and co-design in neurodiverse provision. So Connecting Through Stories and the 100 Stories Project is a new initiative we are beginning here in North Wales. And I say beginning, I sort of put the part on beginning because I really feel that it's something that could be rolled out as a Wales approach. And the project begins with how we harness the power of storytelling. Next slide, please. So we know that storytelling is one of the most powerful methods of human communication and takes place in every known culture in the world. There is a body of research from Dr. Jerome Berner and Dr. Paul Sack, which suggests that stories have a strong impact on our brains, and they can in fact influence how we think and act, bringing into play not only our linguistic processing, but also our emotional response, to the point where we can actually envisage ourselves in the stories, and parts of our brain allow us to design as if we were in the stories ourselves. This can in some cases allow us to develop empathy with the storyteller at a rapid pace, and possibly open up the opportunities to break down barriers in traditional forms of systems communication. Next slide, please. Some of the most effective and impactful stories have been shown to motivate powerful changes in human behaviour and empower action. Social movements are a really good example of this, where the story of one individual can call to action a large number of people in a common cause. But we've all heard stories that have an emotional impact on us, but that doesn't always prompt us to act. The purpose of the 100 Stories Project is to do more than just share stories. It's to create a movement of action to support the development of the wider system around children and young people, motivating our communities and our systems to come with us and support us in the innovative work that's already begun in this forum. Research from Professor Kerr shows that people are most effectively motivated to act when 3 components are stimulated. These can be explained using the metaphor head, heart, and hands, which many of you may recognise from the original work conducted by Pestalozzi's educational stimulus model. Next slide, please. And next slide again. The head represents our rational drivers and cognitive preferences. It's essentially our evidence-based rationale. Show me the evidence to support what you're saying and why it should matter. People who are head-based often are more influenced to act when you demonstrate your evidence base effectively to them. Sometimes people associate this with preferences, with our cognitive preferences linked to data people. Show me the facts and the figures. That's what will make me act and do something about this problem you're talking about. Although it's important to note that this isn't always the case. Next slide, please. The heart represents our emotional and often unconscious motivators, the things that matter most to us. This is one of the most powerful human motivators to prompt action. We've all heard those stories that inspire us and that can emotionally connect with us, that make us want to get up and do something about it. Next slide, please. And the hands represents our skills and abilities. One of the main motivating questions we sometimes ask ourselves before we get up to do something is, do I have the skills and abilities to do something about this problem? Can I do something about the information that I've heard here? Next slide, please. The 3 C's model suggests that if all of these human motivating factors are in place, then we are more likely to get up and do something about the information that we receive. Next slide, please. This brings me on to the final component of 100 Stories, which is built on the effective storytelling method developed by Professor Marshall Gantz, known as the public narrative. This is where you include human motivators of head, heart, and hands into a story to have the most effective impact on your audience. And each story must contain a clear ask of what you're wanting your audience to do next. As we haven't got time today, I can't share with you an example of a public narrative, but Kath and Anna really kindly offered to share an example of this to you after we've completed the event today. So thank you very much to them. And just to forewarn, this is my own personal public narrative around my experience as being a neurodiverse child. So I knew I could share it because I had given myself permission. But also just to let you know that that is what it covers, but it felt very relevant to talk about that today. So next slide, please. So the 100 Stories Project will complete this work across North Wales, gathering public narratives from professionals, children and young people and their families to not only provide a 360-degree evidence base for our current position, but also to call to action our communities to join us in the ongoing co-production and co-design of services and systems around children and young people. Next slide, please. The project will take place through 4 stages: training and support, which will include support for people to develop their public narratives and share their stories in a compassionate and comfortable setting; to develop a series of filmed public narratives, as well as other public narratives through written and audio narratives and artistic narratives; and then to complete a thematic analysis of the evidence gathered through the public narratives and final report, which will be supported by the University of Glyndŵr to give it academic rigour. Finally, we will give people the opportunity to join us in workshops and ongoing events to formulate a 5-year strategy for North Wales, which will be supported by the co-production network. Next slide, please. Next slide again. And I'm really pleased to report that we've already started some of this work and piloted this approach. In our Families Achieving Change Together pilot, which was a really brilliant pilot that has shown us some amazing results. And it was a holistic model of support for children and families provided through partnership in the third sector, clinical staff from BCU services and through the local authority support. And it had an amazing amount of positive feedback, and we actually evaluate the project using the 100 Stories model. So we used it through gathering the stories of families to evaluate the project, which is another way in how this model can support the ongoing research and co-production of services. We also have started the project, which I'm really excited about, which is Impact Through Stories Leadership Programme, which we have piloted in schools across Flintshire with 50 children so far. And it is about teaching children about their rights, but also how to develop their own stories and public narratives so that they can do something about the subjects that they're passionate about. And we can give them the skills and confidence to be able to advocate for other children and young people and share their stories across Wales. Next slide, please. So finally, just to finish off on some of the things I've been talking about, I wanted to share with you a quote from Marshall Gans that always inspires me when I think about some of the big challenges that we all face and that have been discussed here today. It's easy to feel like David when you're up against Goliath problems. So I just want to leave you with hope is the belief in the plausibility of the possible, as opposed to the necessity of the probable. It's always probable that Goliath will win, but sometimes David does. Thank you.
Thank you, Christy. That was a lovely presentation, really uplifting, and we look forward to inviting you back for future meetings, hopefully, to hear how that work's going. I've now got the pleasure of welcoming Rain to our discussion. Rain's going to speak to us on behalf of the National Youth Stakeholder Group. Over to you, Rain.
Thank you. So I've written a poem and a short speech that I'd like to share with you. My name is Rain. I like to write. I wish I was a star and could shine bright. I like to play the piano and sing. I'm not a fan of the social ring. I wish I were a social butterfly. I wish I could be your normal average guy. I wish I understood the world. I wish I could fight the monsters that are unfurled. I wish I was young again and carefree. I wish I didn't always say yes and agree. I wish I could get away with acting like a child, but without my adult mask, I'd be exiled. Why do I hate the feel of sand beneath my feet? Why do I find it hard to know what time to eat? Why do I feel afraid to leave my house? Why do I run around flapping and squeaking like a mouse? Why do social gatherings make me want to scream and weep? Why do I get attacked by monsters whenever I try to sleep? Is there a place for me on this earth? I feel like an outsider from birth. I stalk around in my cryptid form. To social rules and groups I will never conform. But there is a person behind the chilling mask. A person who is alone and wants to be loved if only you'd ask. A person who tries their best but often gets it wrong. A person who wants to be better and belong. But what about the different? Where do we fit? We just seem to get pushed aside, you'll have to admit. What about the people who struggle through each day, who have to fight a war just to get through the doorway? When I first received my autism diagnosis, I was told that it would open doors for me. However, more doors closed right in my face than opened up. CAMHS discharged me on the premise that I didn't have mental health issues, I had autism, and on the terms that another service would pick me up. This unfortunately didn't happen, and for a number of years, I was left floundering with no support until I hit crisis and got referred back to CAMHS. As an adult, support looks a bit better. I am supported by the adult mental health team in the integrated autism service, and I'm currently being assessed for a social worker and by CNOIS, who are a personality disorder service. But then COVID-19 hit, and oh boy, I got hit hard by it. Everything moved online or stopped completely, and my mental health deteriorated so much I ended up in hospital multiple times. Although sometimes it is imperative that an autistic person go into hospital, that doesn't mean it is an easy place to be. There are other very unwell people who often shout or can get very upset, which is very hard to watch. Also, I went there thinking there would be therapeutic intervention, but there was no therapeutic intervention. It's all in the community now. Whether this works or doesn't work, I'm not sure, but I felt that I really needed intense intervention that I didn't get. On a more positive note, I have decided that I want to aim to become a nurse because I want to help lots of people. I also want to help make the system more inclusive of people like me. Thank you for listening.
Rain, that was lovely and really powerful, and I can see quite a lot of people's faces and they're clapping. That thank you. That poem was amazing. Your speech was brilliant, and I'm so delighted to hear you're interested in considering a career in nursing, because I think you would have so much to give. And no, thank you for that. That was lovely. I think we've had an amazing morning so far, everyone. We're going to move on to our final presentation. We've got a little bit of opportunity, hopefully, for some brief discussion after this. I'm going to pass over in a moment to my colleague, Professor Amanda Kirby. As many of you are aware, there's huge challenges facing the practical delivery of services. Now, today's been very much about education, information, collaboration, but we've still got to face the practical issues of how we actually move forward in terms of practical delivery of services. And one of the things we see as being an enabler of this is how we can best embrace digital technology. Now, there has never been a suggestion that this is replacing clinical acumen or relational elements. It's something about how we improve things, how we enhance things. So Amanda is our collaborator within the pilot phase of this work. Now, this is something that we see as having huge potential. We're very much at the beginning of this work, and I think it's important to emphasise that this work will go way beyond the lifespan of the Together for Children and Young People programme. We're in a phase of, we've proved concept, we're now moving towards a practical pilot phase. We're building things very much in a modular fashion. There are huge opportunities here, but we are starting small, and we don't want to falsely raise expectation around this, because this is not single-handedly going to solve everything, but it will certainly help, is our intention. I would say that I would like to thank, before Amanda speaks, everybody who's been hugely supportive in recent weeks around pulling together a basic library of resource, because a key and quite a unique point about this work is that reciprocity, that if you give us information, we give you information, and it's all about early access to support and help that is not dependent on diagnosis. It's dependent on need, really, in that way. So after my preamble, I'm delighted now to hand over to Professor Amanda Kirby. Over to you, Amanda.
Thank you. Thanks, Kath. I don't know how I can follow Rain after that, because that was wonderful. And thank you very much for inviting me this morning. I think it comes at a time when we've had discussions this morning about bringing information together and how we need to do that. So I'm going to talk you through where we are with the digital tool, where we use it elsewhere, so you've got an idea. And again, that reciprocity of information is really important. So the Neurodevelopmental digital tool comes from a background and passion as coming from I come from health education and a neurodivergent family, so I feel like I'm here for different reasons as well, listening to the different stories this morning and the speakers. But the key challenges I think we have at the moment, when we hear from other people as well this morning, is a consistent capture of information asked in an accessible manner. So how do we get information that people can input if you've got a literacy difficulty, if you've got a challenge answering questions, if your English isn't your first language, for example, as well. Collaboration between systems of care, how do we bring information from multiple sources, gathering different voices, hearing the voices of the parent, child and other people to complete a formulation. The ability to capture a cumulative load. I enjoyed Helen's talk at the beginning of the morning, and it just re-emphasises how that we need to be gathering this information from different sources. The transdisciplinary information together, we're hearing from different people this morning as well. Delivering guidance upstream of processes and giving functional help, feeding into what Kerry was saying of what parents want. They want practical guidance, even if they don't get a diagnosis, but they want practical advice. And that practical personalised guidance. So what do I need for my family, for my child or young person? And then I remember myself telling my child's story again and again, reducing the need to tell your child's story again and again. And then the strengths approach, as well as capturing specific challenges that Kerry alluded to as well. And then educational guidance to have consistent approaches, so getting information back as well. And then locally targeted guidance that is pertinent to Wales as well. And easy access to monitoring tools. Okay, so that's what we'd like. I'll show you where we are in the discussions and what the system can do and where we can potentially go. So the Do It Profiler system is used in the community. This is where we use our wider system. And then I'm going to tell you about what we're doing with the neurodevelopmental tool in Wales. It's used in the community with parents, housing, youth services. It's used directly with schools, college, universities and alternative provision and specialist school settings. In Wales, clinical settings for reducing and aiding management of waiting lists, for monitoring tools. It's also used in other settings, into employment, apprenticeships and traineeship, employment, prison and probation. For instance, it's used in Cardiff Park and Swim at Swansea, and in the pilot for probation services. And we've got a project going with homelessness prevention in Cardiff school, in Welsh schools with Cardiff University. So what's the system? So the system that we're using, we're taking a modular web-based system. And I often use blocks because I think it's an easy way of those modules that sit on a management platform. It's accessible, so it's voiced. You could hear questions spoken to you. You can hear information repeated if you need to. So if you need to process that information, it's translatable. And we're in the pilot, we're starting to do this bilingually, but the potential is it can be in multiple languages as well. Spoken as well as read. Keep thinking about that accessibility piece. It's a bit that really is important. Deliverable on computers, phones and tablets, so it can be taken and portable anywhere, and it's enabling information to be brought together from multiple inputs. So the input from multiple sources may come from the parents and carers, from the young people, from educators, from allied health professionals, social services, feeding into the clinical team that's collating this documentation. And then in the outputs are going out to different audiences, but different information that's pertinent to those different audiences. So parents and carers upstream can get functional support and guidance, young people too, educator, and then out to the other where appropriate. We're starting on this journey. So I'm not saying where we are, but where we'd like to go. So the benefits of the system are that it is adaptable, it's modular. So the content that's going has been through a collaborative process. There's been brilliant because people feeding in and saying what they want. What does that look like? Building on what we've got and what is good clinical practice. But you can add new modules. So we've been talking about, so you can add other Lego bricks into folders. We can segregate the information. We can decide where information goes out and where information goes in and who it goes to. And it can be contextualized to those areas. It requires limited digital skills. We've used it in hundreds of systems, been used in hundreds and thousands of people. Delivers a whole child and young person-centered approach, and it empowers the parents because when they put the information in, they get some practical and functional guidance without the need to have a formal diagnosis. So they can start with some very practical resources while they're waiting or they're moving through a system. So it's not an either or. There's two sides to the system, front end for the parents. Parents enter the information, generates the report and guidance for them. They don't have to keep repeating the same questions because they've got that log and they can edit it. The child and young people can enter information depending on their age and stage as well, where appropriate. And then the management dashboard is for the clinicians, their staff view, gives an overview, the full picture of inputs going down to question by question level, and a resource library. So this is just a quick sort of look. You've got a video where the parents first to know how to use the system and accessibility, which will be tailored to Wales specifically for the project. It's accessible, showing how to use turn sound on or off and everything as well. The potential, we're having it bilingually, but it's potential, as I said, for other languages. But there's different layers of information that's going to be collected. So the parent in the project we're working on now is that the email will be sent out to the parent complete it in their own time, they can edit the content, the report can be saved, so reducing the need to keep providing that information, and then potential for email then is going to be sent to the administrator, clinical administrator, to know that's been completed. So the parent gets some practical guidance at stage 1 around strengths and looking at their practical resources, helping things with like processes. It's easy to complete and it's voiced. They can work through this at their own pace. And we limit the text entry, and we've got a spell checker in there as well to limit it, but we've got qualitative information as well. It generates a report straight away. Nobody's got to input anything. It's there for the clinician to see straight away. And we've got targeted spots to say where there are background information of interest that we might need to look at more specifically. Generates pictures of a spiky profile. This is a strengths-based approach as well. So we're looking at where the strengths across a neurodevelopmental, neurodiverse profile is, strengths as well as challenges, which are age appropriate. In the pilot, we're focusing on 7 to 11-year-olds. And then those practical resources, which we're aiming to pull together now from different people from the different agencies, not reinventing the wheel, but respecting the differences that the major and amazing resources that people have already got, but ensuring that we got some standards so we can pull those together and they can be given to the parents depending on their responses. So this is a child-centered, family-centered response. They get what they require rather than a pack of resources. And then we can do things like potential links to local services for North Wales or Cardiff or where, so they can be particularly for those areas as well. So the clinical service gets the information, they've got all that in one place. There's a module we've developed for clinical input, which can be edited and added to. The clinician can see the management dashboard, go in and see that young person, see all the information, they can download the report if they require. They can see the parent guardian, what they've completed, filling this in. It's all generated. There's no administration, and then the clinician complete their clinical review as well to add to that, and that's all documented and dated. And then, as I said, as more modules are used, they can be added over time as well. The resource library will be building up. We have a lot of resources, but we're going out and then to pull those together to ensure that we are getting the best in the resource library and collating those at the moment, just starting on that. And then it sits on that management platform where all that data is all collated and you can see it instantly. So you can see things like activity, which families have completed the neurodevelopmental tool, and also you can pull off group data, so at a clinical level, but there is a hierarchy of access. So there's permissions, of course, for security about who has access to the information. So finally, just a review, and then I've gone through quite quickly because I know that it's a lot of information. Some of you will have heard it before, but the neurodevelopmental digital tool, we're aiming to have a consistent approach aligned to child-centered whole school approaches. It's a tool, and I emphasize that. And as Kath was saying before, it's a tool to assist in gathering information to help inform decision making. It's not to take away clinical acumen. It's to bring things together to help to inform. Strengths-based, functional needs led with practical resources can be used upstream, and further tools then we can use as the child moves in if they gain a diagnosis, and intervention. Adaptable, so you can add those other bricks in, accessible, translatable, and we hope reduces data entry time, and delivering that segmented guidance so school can get information about the child that's appropriate for them as well. So I shall hand back to you.
Thank you, Amanda. That was great. A real whistle stop through the digital tool. So I think for many of you, you will have seen some information relating to that previously. I would explain that at the moment we're on a journey with this. As Amanda has suggested, there was some existing technology which was pretty unique really in its breadth, its accessibility, the way it worked with information, and we're now developing that into a tool specific for Wales that will become part of a clinical record. And I'm sure you will recognise that with that sort of progression of work, there are lots of challenges around information governance, security, data protection, etc. So we're now just about to enter into that phase of piloting it to sort of really knock it into shape and to develop it. And we're looking really to take all of you on that journey with us. We're also looking as well to Welsh Government and to the nation really to decide our future direction of travel. And I think a lot of this meeting is about that. What are we signed up to in Wales, and how are we going to deliver that in Wales? Because everything you've heard suggests us to the complexity of this. And I think going back to some of the earlier presentations, Kerry's comments about earlier child development and links with services that are perhaps not traditionally seen as being part of a neurodevelopmental service, links to partner agencies, links to parents and carers groups, links to different third-party groups, that it's huge in that way. So we're really looking to cement the future of this in Wales, and that's part of the rationale and the meetings that are following on next week. Now, Deb, you've been keeping an eye on the chat, I know. There's lots of comments and discussions in there. Can you pick out any specific questions that you want to raise? Because we've got the option now of maybe throwing it open to everybody to have a, it might be slightly chaotic or it might be very quiet, to see if there's any questions we can raise from the audience, really. Anything from you, Deb?
I guess the one question, just to clarify, and I responded in the chat box about it, was about the modules. And Kath, maybe to expand a little bit on the sequencing of the build of the 5 modules.
Okay. So we're starting with the basics, which is the parent information and the clinical module. So obviously the parent is inputting information, and then the bit that is the development in Wales is almost then developing a model that is fit for the clinician to use, which reduces duplication, increases efficiencies, but also becomes part of that clinical assessment. So there will be options within that to both start building the summary. Many of you will remember back from the national standards that a key part of that is you generate a summary, because that's part of your formulation, part of your communication strategy, and yet most of us are struggling to do that simply because the throughput is so great. So you're missing that key element of communication. So this profile builder should help us develop that clinical summary. There's also the additional possibility of it developing into a patient management element that helps increase, again, the efficiency and the throughput. You know what you need, you're seeing people at the right time with the right information. So that's your patient and your clinical. There's obviously a key module, which is the young person's voice. Now, that is obviously going to have to be designed and suitable and accessible for children with different elements of need, different ages, etc. in the future. There's also the element of education. I think most of us would agree that information from education is a pivotal part of any assessment. So again, modules with education. Those are in the process of being developed and being communicated with teams with ALN leads, DECLIOs, ALN transformation leads, teaching representation, because we don't want to duplicate things here. We want to make this as simple and as useful as is possible. And the educational element is likely to be both sort of baseline information, and we could term it in different ways. It could be around attainment, and barriers to learning, but also a neurodiversity screener that tells us more about the neurodivergent individual in that way, but at a population level, it's more about a screen. So the 5th module is potentially that interface with social care and partner agencies to get that bigger holistic picture, really. That module, I think that's probably going to be a more challenging module to develop, and we've got that 1/5 in line at the minute because of some of the potential sensitivities and wider issues, but I think it is probably an essential one where it's appropriate, because we are also talking about support and interventions in that way. So I hope that answers the question around the modules. Potential for future modules, but those are the first 5.
Okay, thank you. Kath, I think this is probably a question for you. And my opportunity to throw something back, I guess, in the questions I've picked up again in the chat bar. The introduction of the 15-month health visitor assessments is leading to increased early referrals. What are your thoughts around the resource implications of that, and have they been considered in the current development of ND services?
Yeah, a really good question. I think it hints really at this whole question of whole system approach, doesn't it? I think the honest answer to that is when we're looking at the development of services, I think we already have a challenge when it comes to capacity and delivery within the more specialist and core elements. And I think it is essential that we then go out and we map beyond that. So I think that's more work that needs to be done, to be quite honest. I think there are huge opportunities there. And I think we were picking up on it during Kerry's presentation, really, about, again, that systemic approach with health visiting. She also alluded to school health nursing. And I know that's something that's very much come up in discussions about the impact of COVID, in that we already perhaps had challenges with the capacity and the focus and where we were directing, not where we were because I wasn't directing it, but about school health nursing. But a lot of that workforce has moved now into vaccination, for example. So the answer to that in my mind would be no, it's not within the remit of the specialist ND core. Yes, it is within the scope of a whole system approach. And yes, it must be part of that future discussion about the lifetime model.
Okay.
So would you come back on that with anything?
For me, I think you've answered the question, which is around if we are to take a neurodiverse approach going forward, it'll require a new fundamental shift in the funding formulas allocated to support these services. And how and where we pull that together will be a really important next step.
And I think you're highlighting, I think I said it a couple of times already this morning, but it is that commitment to what is the approach in Wales. And if we go beyond that approach in Wales, how do you truly deliver a systematic approach? Because this would go beyond professional groups. It also goes into our approaches, our strategies, perhaps around areas as diverse as trauma and trauma-informed approaches. It gives us opportunities for policy alignment. And I would say that one of the key actions of the Together for Children and Young People group, and certainly a high proportion of our time, is spent trying to do that cross-policy alignment. So there is the question of what will be the mechanism for that once the time scale of the programme has passed. And we're looking forward to seeking really a commitment from government around that cross-policy approach. I think there is the appetite for it and the enthusiasm, and I think everybody agrees that it's now the practical delivery of that is the key issue.
Yeah, okay, thank you. There was one more question, if I may, and it's for Christy. Christy, really taken by the stories and the project, really interested in how that work could be used to maybe shape future evaluation frameworks. And what thoughts have you had around that?
Well, we've actually started. So as I mentioned, with one of the pilots that was actually funded by the Transformation Programme, which was our FACT project, we actually used it as the evaluation mechanism. So we used it alongside data information and survey information, but we used it as a real detailed storytelling evidence base. So we worked with the families and tracked their experience from birth, essentially. So we had the discussions with the parent from birth up to where they were now before they received the support, and then following the support. And again, we will track again, after the support has sort of left, what happens from there. So it actually provides that really detailed picture that sometimes we don't always get when we do evaluations. It's really difficult to actually track someone's journey. And I think, across Wales, we've been trying to find different ways of doing this, actually. And I think that the stories method, the 100 stories method, is certainly a way that we could potentially start to do this and give us that real detailed understanding of what actually is going on for families and what is the real impact, because that's really what we need to be able to design and develop services in a really informed way. So that's where I think it really comes into its own and can be used, if that's helpful. And again, I'm happy to share some of the findings from the FACT project if people would like to see the kind of evaluation method in action.
Thank you, Christy. Thank you. Deb, is that everything from the chat?
Yes, Kath.
Brilliant, brilliant. So thank you, everybody. I'm going to draw our meeting to a close. As I do so, I would encourage everybody to give us some feedback. There's the link at the top of the chat. There was also a link in an email that you were sent this morning, really so that we can continue to deliver things and make useful contacts and useful sessions. But I hope everybody has enjoyed it this morning. I think it's certainly more fun than a business meeting. I definitely want to thank everybody who's contributed. Our speakers have been excellent, really well informed, really well prepared, really interesting. Thank you so much for putting your time and effort into this. Thank you for our poster makers. They were brilliant. Please remember those details, contact those teams. We're going to continue this work and this collaborative work with all of you. It's not an easy win, but we are getting there. We are making progress, and let's give everybody best wishes for the summer months. I look forward to getting back together with the steering group, with the clinical leads group, with all the neurodevelopmental teams in the early autumn. And I'd like to wish you all the best for the weekend and for the summer months. But thank you, everybody, for your input and your contributions. It's much appreciated. Thank you, everybody.
Thank you all, and thank you, Kath.
Thank you. Thanks, Kath.
Thank you. We'll
you.
share all the
Thank you so much.
presentations. You're very welcome. Thank you.
It was great, guys. Thank you so much, and I'll look forward to receiving all the materials. Take care now.
Thank you.
Thank you. Thanks, Annapurna.